Thank you everyone for joining. We're going to be starting in about 2 minutes. We're just allowing a few more people to come in from the waiting room. So just give us about 2 more minutes and we'll get started. All right, it is 7:02. So I am going to go ahead and get us started. Thank you all for joining us tonight. My name is Monica Shockley Porter, and I serve as the co-chair of programs. And tonight I have the pleasure of sharing with you a little bit about our program tonight. So first, I want to just share with you about the National Coalition of 100 Black Women. We here at the Delaware chapter, our mission is to advocate on behalf of Black women and girls through national and local actions along with strategic alliances that promote leadership development and gender equity in the areas of health, education, and economic empowerment. We are in challenging times and Black women are being impacted physically, financially, and emotionally by the COVID-19 pandemic. Here with the Coalition of 100 Black Women, we're a group of women whose mission has always been to advocate on behalf of Black women. We have felt that it's critical to develop a message and programming specifically for Black women and our needs during the pandemic. Sisters Saving Sisters Beyond the Mask is our health equity campaign. The goal of our monthly programming is to assist Black women in coping and share health resources, provide a safe place to connect, and most importantly, to have a seat at the table in developing and advocating for health equity policy. We are also serving as a resource and encouraging women to do research for themselves and for their families to determine what is best for them when it relates to the COVID-19 vaccine. We are proud of this campaign developed by Black women for Black women. For more information on this campaign, please visit www.beyondthemask.info. And you guys can see the Beyond the Mask site there on the screen share. We have also created a medical advisory group consisting of Black female physicians who are leading the COVID-19 response, including the vaccine. Dr. Scantleberry is one of our leading physicians in this health equity space. We are concerned, like many people around the country, about the rollout of the vaccine. Our communities are getting sick and dying at a far higher rate than the general population. But what we are seeing in Delaware is that the rollout has not been specifically targeted to communities that are disproportionately impacted. Tonight, our focus will be on kidney health. We will explore kidney disease, the silent killer, and learn about the importance of knowing your numbers. I'm going to turn it over to my co-chair, Tamara, to introduce Dr. Scantleberry. And then after that, we're going to take a short poll just to get a feel of who's in the room. Tamara, I'll turn it over to you.
Thank you, Monica, and good evening to everyone. It is my pleasure to introduce Dr. Velma Scantleberry. She is the Associate Director of the Kidney Transplant Program at Christiana Care. She accepted a position at Christiana Care after working at the University of South Alabama's Regional Transplant Center, where she served as a professor of surgery, Assistant Dean of Community Education, and Director of Transplantation. She has been named to both the Best Doctors in America and Top Doctors in America list multiple times. She earned her medical degree from Columbia University in New York City. She was an intern and resident in general surgery at Harlem Hospital Center in New York City. She completed her fellowship training in transplantation surgery at the University of Pittsburgh and then joined the University of Pittsburgh School of Medicine as an assistant professor of surgery in 1989. She rose to the rank of associate professor prior to her appointment at the University of Southern Alabama. Dr. Scantleberry's special interests include researching the end results of donation and transplantation in African Americans, increasing organ donation in the African American community through education and awareness, like tonight's event, increasing the incidence of living donor transplantation by education, and treating viral infections. We're looking forward to hearing her speak tonight. I'll pass it back to Monica to do our short poll before we hear from Dr. Scantleberry.
All right, thank you so much, Tamara. So tonight we want to get a pulse and get a feel of who's in the room. So I'm going to launch our first poll. And you guys let me know if you can see this. Are you able to see the poll on the screen about your relationship with kidney disease? So the first question is, how has kidney disease impacted your life? So if you can go ahead and choose and select your answers, I'll close the poll in 1 minute, give you guys a chance to make your selections. All right, we have about 50% of you all have voted. Okay, I see it increasing. Wonderful. All right, we'll give it a few more seconds and then I'll close the poll out. All right. I'm going to go ahead and share the results with you. So it looks like there's about 6% of you here that have been diagnosed with kidney disease. 56% of our attendees tonight have a family member with kidney disease. 44% know someone with kidney disease, and 11% are just here, I guess, because they want to learn more about kidney disease. So that's wonderful. Kidney disease has not had a direct impact in their lives. So I'm going to launch our second poll. Let me get this out. I am learning as we go in polls. All right, wonderful. All right, we will come back to the second poll after Dr. Scantleberry gets started because I'm having a little bit of technical difficulty getting the second one launched. So Dr. Okay, Dr. Scantleberry, we'll turn it over to you.
No problem. Thank you so much. And so I will switch over to my presentation. Thank you guys so much for having me here tonight. This is truly an honor and a pleasure to speak about something that's really dear and close to my heart, and that is kidney disease. And so let me see if my computer would, there we go. And so we're going to talk about this, and it was one interesting that it's titled The Silent Killer, because most of the patients I see and people who I discuss this with are so surprised because there are no symptoms of kidney disease in reality until it's at the end or very close to needing severe treatment for it. So where are your kidneys? They really are posterior in the back of your abdomen near your rib cage. They're protected by a very large layer of fat to prevent them from being injured. Or, if someone punched you in the ribs and your ribs are broken, you don't want that to cause an injury to your kidneys. The majority of people have 2 kidneys, are born with 2, but there's some people who only have 1, and that's generally due to some congenital or issues at the time that you're being developed as a fetus. So 1 kidney can really do the same work of 2 kidneys, and oftentimes can enlarge and be much greater than normal, and most kidneys are about the size of your fist. So let's learn the facts about kidneys and kidney disease. So what exactly does your kidneys do? Your kidneys are bean-shaped, about the size of a fist, as I just said, and they regulate your blood pressure. They control whether you need to put out more urine or put less urine. out depending on how dehydrated or how well hydrated you are. They filter your blood all day long. So all your blood gets filtered through your kidneys. And in doing that, it removes the waste products from the body. And so it balances your body's fluid intake. And like I said, if your blood pressure is low or you're low on volume, you would realize that you're not going to urinate as much because it wants to regulate this as the blood flows through. There's a monitor that tells it whether you need to hold on to your urine or not. The kidneys also make important vitamins that makes hormones that activates important vitamins such as vitamin D for healthy bones. So as we go on in age, we need to make sure that we have adequate amount of vitamin D that your kidneys are processing, as well as making what we call erythropoietin, which is a hormone that keeps us from being anemic. So this hormone is directly produced by your kidneys and allows you to make more red cells to balance your body's hemoglobin. And so if you have a low hemoglobin, while it can be due to many things, it can also be due to kidney disease. And the fact of the matter is that when we look at information from the CDC, we find that there are 37 million people estimated to have some level of kidney disease. And that's about 15% of all US adults. And so most adults do not even know they have kidney disease. So about 1 in 7 people will have kidney dysfunction, what we call chronic kidney disease. And 1 in 2 people with very low kidney function who are not on dialysis may not even know that they have kidney failure. And so when we talk about kidney disease, we're actually mostly referring to chronic kidney disease, because acute kidney disease is something that happens when your kidneys stop working suddenly. And the doctors may refer to this as acute kidney injury or acute renal failure. And this is generally due to conditions that are reversible, such as blood loss. If you had an acute blood loss from a trauma, accident, or an operation, you may have some acute injury. Your numbers may be slightly worse, but with correction, such as also dehydration, you can go for days without drinking fluid and your kidney function may worsen. But with correction of that acute injury can be reversed. Direct damage to the kidneys, such as in trauma, motor vehicle accident, and all those things may cause an elevation of your kidney function. You can also have what we call obstructed issues with your kidneys that will allow your urine to back up into your kidneys, such as kidney stones, prostate. One of the things you have to realize is that you can, now with COVID-19, it can result in kidney injury. It can be acute in the sense that if you're admitted and your creatinine is worse, it can often be improved upon once your disease improves. But if you remain hospitalized for a long time or have underlying issues already with your kidneys, it can often lead to kidney disease and kidney failure, with many patients ending up on dialysis from COVID-19 infections. And so one of the things that when we talk about that acute process is different from what we said, chronic kidney disease. And so the progression of chronic kidney disease is a slow process, going from having normal kidneys to being at risk. And some of those risk factors we'll talk about in the coming slides. And those risk factors and those disease processes will then cause kidney damage. Kidney damage will then reduce your overall working ability of the kidney, leading to kidney failure. So the progression over time of chronic kidney disease is what we discuss and what we're trying to give more information about, so that we can decide or to keep as many as possible from going on to kidney failure, or at least knowing where you're headed. So when we think about kidney disease and chronic kidney disease, the two leading causes are things that we encounter very often: diabetes mellitus, and this is what we call type 2 diabetes or adult onset diabetes, and high blood pressure. There are also non-specific causes that we'll talk about, but approximately 1 in 3 adults with diabetes and 1 in 5 adults with high blood pressure may have chronic kidney disease. And so that's very important because as a community of color, these are two diseases that we're often have to deal with, and we need to be aware of the possible consequences. We know that there are other groups of diseases such as lupus, chronic use of medications, and other diseases that lead to chronic kidney disease. So when we talk about the progression of chronic kidney disease, there are generally 5 stages of chronic kidney disease. Treatment and lifestyle changes can help slow or prevent your kidneys from getting worse. So when we talk about normal kidney function, you're really what we say stage 1. This is normal. Your what we call GFR, or your glomerular filtration rate, that's the rate at which your kidneys process your blood and filter your blood, is still about 90% or greater. So that's, we know, is quite fine. As we get older, we begin to drift down to slightly more problems with our kidneys. Stage 2, you have mild loss of kidney function, and now your kidneys are only functioning about 60 to 90%, somewhere around averaging about 75 to 80%. Stage 2, not much to worry about, but need to be focusing on in terms of progression of disease over time. And this is why it's important to know your numbers from year to year, because suddenly if one year, like last year or 2019, you were at stage 2, well, not much a big deal, but then you went into 2020 and we had COVID, and you were home, haven't gotten your blood work, haven't seen your physician, and now we're into 2021. So a whole year has passed. And what happens if you return finally after more than 12 months to get your blood work, and now your GFR or your filtration rate is now much lower, down to 50 to 55%. Now you have mild to moderate kidney loss of function. And that becomes important to understand, because now you have progressed slowly and unnoticeably, because more than likely there were not many symptoms. And so when you get into less than 40%, 30 to 40%, you're then into the moderate to severe loss of kidney function. So if you think about that, only 1/3 of your kidney function is functioning appropriately, and 2/3 is not. And so you're building up more and more waste products. At 20%, on average, 15 to 30%, most people at this point, your physicians or someone needs to be, or your nephrologist need to be thinking about where you're headed. What are the options for this? Are you headed to stage 5, which is failure and the need for dialysis or transplantation? So this is a critical stage where intervention is needed. The earlier, the better. And so it's important to know that this, as we age also, we're dealing with these factors as most of us, when you're over 65 or 70, you may be already in stage 2 to 3 because of just age alone. And if you have underlying problems or comorbidities such as heart disease, anything that affects your overall blood vessels, diabetes and hypertension, you're already losing function with your kidneys. And none of this there may not be any significant symptoms to alert you to that, except for blood work or checking your urine. So when we think about other causes of kidney disease, we know there's polycystic kidney disease, and this is usually autosomal or inherited, genetic in some sense, can also be sporadic. Drug toxicity from things like cocaine abuse or heroin, or even some psychotic medications, can cause injury to the kidney from long-term use. Things like sickle cell disease, sarcoid, lupus nephritis, seen mostly in women, but a few men, and occasionally hepatitis C can also lead to kidney disease. So when we look at the reported causes of kidney disease in the United States, the largest group is for type 2 diabetes. Certainly, African Americans tend to have a higher incidence of high blood pressure, because high blood pressure is more difficult to treat and leads to kidney disease about 3 to 4 times more than the average Caucasian. So kidney disease is silent. By the time you have symptoms, you are in the severe stage 4 to 5 stages. Symptoms may be related to the inability of the kidney to do its job. So you may have more fluid accumulation. You may find that you can't get your shoes on at the end of the day. Anemia and low blood count. Unfortunately, I've seen so many patients who were sent to a hematologist or blood specialist because their blood count was low without anyone realizing it was low because they had chronic kidney disease. I went through a remarkable workup with bone marrow biopsies only to find that it was because they were in renal failure. So it's important to look at everything as a whole. Fatigue and tiredness, and you have to remember as well as memory loss, is because once you start not filtering your blood, all these metabolites are going to accumulate in your body. And with the accumulation of these things, you will often suffer from a buildup of such waste products on the brain. You will be more tired. You will find that you need to sleep a lot more. And that becomes just inability of your blood to know what to do with those metabolites that will normally pass out in your urine. So what are the risk factors and what the end results? And so kidney disease, we talked about diabetes, high blood pressure. But we also have to think about obesity. We also talked about age, family history. We know we have to really talk about what is your family history. Oftentimes as African Americans, we try not to talk about family history, but it's important to know what are your risks. And certainly with diabetes in itself, it causes buildup of atherosclerotic plaque or lipids within the lining of your blood vessels, what we call plaque disease or atherosclerosis. It softens the lining of the blood vessel, and so therefore you're more at risk for heart disease. So is high blood pressure. While it may affects more than just the blood vessels going to your kidneys, it affects so many of these, both high blood pressure and diabetes affects a narrowing of the blood vessels to your heart, to your eyes, to your feet, to your legs. Blood pressure in itself causes buildup of the muscle within the lining of your blood vessels, which then leads to narrowing of your blood vessels. And we say high blood pressure, silent killer also because it can cause sudden heart attacks, stroke, and sudden death. So once these blood vessels are no longer able to get the blood through to the important parts of your heart, you will suffer as a result of blockage. And so while understand that these diseases are what we call systemic, it appears and can affect almost all your blood vessels in your body, from your brain to your eyes, causing stroke, causing vision problems, blood clots, causing kidney problems, causing problems with your legs, and peripheral vascular disease. Obesity in itself, age, diabetes and high blood pressure, plus obesity, all lead to heart disease. And the leading cause of heart disease is the number one, heart disease is the number one killer, especially for women and African-American women. And we need to think about the underlying risk factors of diabetes and high blood pressure. So when we think about the ethnic differences in kidney disease or kidney failure, we say end-stage renal disease. That's when you get to stage 5. Diabetes certainly is the leading cause. African Americans, I said, is 3 to 3.5 times more likely to develop kidney failure compared to Caucasians. Hispanics suffer from mostly from diabetes and are 1 and 1.5 times more likely to develop end-stage kidney disease than non-Hispanics. Native Americans have a higher incidence of diabetes than non-Hispanic whites, and African Americans progress faster from chronic kidney disease to end-stage kidney disease, leading to overrepresentation amongst those that need dialysis. And this is very important to know, because if I take a Caucasian and an African American who have a stage 2 kidney disease, a year later, that African American may have stage 3 kidney disease. 3 years later or 5 years later, they may be on to stage 5, while that Caucasian patient may still be at stage 2 5 years later. So it's important to understand that the progression within African Americans is tremendous and needs to be followed. And this is the importance of knowing your numbers. And so when we look at some papers, this is the prevalence of chronic kidney disease by race and ethnicity. As I said before, the relative prevalence of stage 1 to 3, according to using the glomerular filtration scale for whites, blacks, and Hispanics. Certainly the risk is slightly the same, a little bit more for whites and less for Hispanics in the early stages, but you move on to stage 5 and end-stage renal disease, and what do we see? The risk increases tremendously for African Americans, Native Americans, and Hispanics, less so for Caucasians and for Asians. So that's very important to understand why it is important to control your blood pressure, control your diabetes, and to be monitored. Know your numbers. When you look at the rates of kidney disease by race, with this burgundy line being African Americans standing out with higher incidence and rates per million compared to American Indians, Asians with everyone all together, and Caucasians on the bottom of the line. So this is our risk factor. And if you didn't have heart disease before you develop kidney disease, you will develop heart disease just by having kidney disease, kidney failure. So when we look at chronic kidney disease, it's really an unrecognized public health issue, because when we think about high blood pressure, there's so many, 94% of people are untested or are not aware of having high blood pressure. Diabetes, 61% untested. And having a combination of diabetes and hypertension, 60% go untested. So hypertension and diabetes are the two highest risk factors for chronic kidney disease. And many people are not receiving the recommended testing. You need to know what your creatinine test is. You need to know, are you spilling protein or albumin in your urine? And a simple spot urine can give you that information. So many of us go to the physician, we get blood work, check your creatinine, that's fine if it's included. Make sure you know your numbers, make sure your doctors, if you have diabetes or high blood pressure, is checking your creatinine, protein creatinine ratio. So as I said, 90% of adults with type 2 diabetes are currently not diagnosed. And so this is important for me to understand that many patients are diagnosed with kidney failure and advanced kidney disease in emergency room and not systematically aware that they are slowly losing kidney function. So it's important to have two tests to assess for chronic kidney disease: your estimated GFR and your urine albumin or protein creatinine ratio. It's easier to remember, protein creatinine ratio. And when you get your blood work, get a copy of your results, because it will tell you whether your values are within normal or whether they are abnormal. And it allows you to ask questions of your physician. And current guidelines for chronic kidney disease recommends that adults with diabetes and or high blood pressure be evaluated every year to check for that protein in your urine. So if you're not getting it and you somehow fall into this group, you need to make sure or notify your physician that this is something important for you to understand, that you want to know what it is. And these numbers are not just numbers that stand by themselves. It's a progression or trend. You want to know, what is the trend? Is the trend going up, or is it going down, or is it staying the same? So an isolated number in itself doesn't mean much, because creatinine can be increased by so many factors: dehydration, eating a lot of meat. So many things can affect that. So it's important to know what is your trend over time and keep a log of your numbers. So one of the issues we face is that as we progress and as patients progress with chronic kidney disease and are under the care of their primary physician or primary caretaker, healthcare worker, you want to make sure that someone is monitoring your kidney function. If you start to decline, you should be referred to a specialist, which is called a nephrologist. And so when we look at data for patients who were referred to the nephrologist within the 12 months prior to needing treatment for kidney failure, such as initiating dialysis or being referred, we find that less than 25%, or just about 25 to 30% of non-Hispanic Blacks and for Hispanics are the two lowest group that do not get referred to nephrologists. So if your primary physician, if you know you have any kidney abnormality, someone needs to be rigorously monitoring the decline, the stability, and making sure that intervention, correction, when you see a nephrologist, there may be different things instituted, such as changing medication, dietary recommendations, checking to see if you're anemic, and do you need the appropriate things to build up your blood count. So these things are generally handled by a specialist. Unfortunately, when we look at patients with chronic kidney disease, having low kidney function in that 20 to 30 range, and having high protein creatinine ratio, we can often be almost certainly sure that they are at an increased risk of cardiovascular events and death. Chronic kidney disease is associated with increased worsening heart function and cardiovascular events. So as I said before, both high blood pressure and diabetes lead to coronary artery disease. If you had another diagnosis other than diabetes and high blood pressure, such as polycystic kidney disease or lupus nephritis, kidney disease also presents with high blood pressure. So high blood pressure is not only a cause of kidney disease, it's also a symptom of kidney disease. And that's important to understand. So as your kidneys fail, your blood pressure will get worse. High cholesterol is seen in patients with chronic kidney disease, obesity, undiagnosed heart disease. Many of our patients have to be sent to have stents and bypass surgery because of existing heart disease. Peripheral vascular disease or blockage in the legs, where you then have pain on walking, inability to walk for long distances due to blockage of inadequate blood to your legs and especially your toes, and is certainly associated with an increased incidence of sleep apnea. So what are the goals of treatment and prevention of kidney disease? And this is from the National Kidney Foundation data. The management of chronic kidney disease includes reducing your overall risk of progression and the associated complications such as heart disease, because that's what's going to be the primary cause of death, as well as acute kidney injury on top of your chronic kidney injury, chronic kidney disease anemia, and knowing that your low blood count may be due to chronic kidney disease, metabolic acidosis, because your kidney regulates the amount of acid that gets excreted from your kidneys. And if that's not working properly, you're going to run into an imbalance of the acid and the base within your blood system, as well as bone disorders and mineral problems. So you have problems with calcium, you have problems with phosphorus, and that leads to what's called hyperparathyroidism. You need to target lower blood pressures. So certainly if your blood pressure is 160 over 180 over 110 or 100, you need to get that blood pressure down. It says higher goals because certainly if someone is running a blood pressure of 200 over 120, you want to improve that, but you do not want to drop them as low as 130 over 90 suddenly, because that person will develop lightheadedness. And so slowly aiming for better control over time is what the goal is, to have that blood pressure not wreaking havoc on your blood vessels. There's the recommendation of use of ACE inhibitors or angiotensin receptor blockers, and these are important for patients who have high blood pressure or diabetes with protein loss, and because these medications help control how much protein is lost from the urine. And if you're diabetic, you need to make sure that your hemoglobin A1C is well controlled, less than 7, with referral for nutritional therapy to decide whether or not it is important to help you manage how you eat and what your diet is. So what do we need to do? We need to get tested. We need to realize that kidney disease is silent. There are hardly any symptoms except towards the end stage where you start having fluid accumulation, difficulty breathing. And for most patients, presentation to the emergency room is because of congestive heart failure, unable to balance that fluid that your kidneys normally would be doing. So you have to know your risk factors. Make sure you get checked annually, and realize it is so important to know your numbers. Know your numbers from year to year. Keep your own log. Take that responsibility for yourself. And if you don't understand what those numbers are or what they're supposed to be, keep a notebook and ask questions of your healthcare provider on your visits, or now we're doing telemedicine. Write that stuff down before your visit so that you are able to have that conversation. And if they're rushing you, just say, 1 more minute, sir, ma'am, I have a few questions for you. And so everyone is in a hurry to the next patient. But remember, you are the customer. You need to make sure that your physician, your caretaker is there to answer your questions. And if you need to, and it becomes necessary, think about your diet, because certainly dietary changes and increased exercise and activity can play a big role in controlling your blood pressure, controlling your diabetes. And we know how difficult it has been during the times of COVID and being home and having snow to get out and walk, but there's so many things you can do. So we can exercise, we can watch YouTube videos, we can dance, we can do so much to get those calories in. So I thank you for this occasion to talk to you about kidney disease. And I hope I've left enough time for us to have some questions from the audience.
Absolutely. So, Dr. Scantleberry, you've been getting some questions in the audience. So let me scroll up and go to our questions from the participants. One of the questions we have here is, why are the numbers so high for African Americans?
Well, our risk factors. I think we now just know that as far as diabetes, a lot of that is we may be at risk just in terms of our genetics, or even in terms of our environment, the kind of things we eat, and what has been passed on for generations. And one of the data is in terms of the sugary drinks that we consume. We love sweet tea, we love lemonade, but they don't taste that great without sugar. So we have to be conscious of the calories we take in that are so much greater than the calories we burn. And it becomes a habit, or it's something that's passed down that we just reach for that sweet drink. And it, just putting aside sodas and getting the sodas away from our young people is interesting, because now we used to be able to say that type 2 diabetes was adult onset diabetes. Now we see adult onset diabetes, or type 2 diabetes, in adolescents, in young people. Is no longer the adult form it's just type 2 diabetes starting at an early age. So we need to be looking at what are we introducing, what is in our immediate past and our environments that we're used to doing that we need to change to break that cycle. We know that a lot of African Americans have a gene called APOL1 that's tested, can be tested to see if you have incident genetic inclination to have high blood pressure. And that's even in terms of organ donation. We know that there's some people who donated a kidney and then went on to have high blood pressure and needed a kidney transplant. And then looking at that population, we find that they did have genetics. And so there's a discussion of who is at risk for high blood pressure and kidney failure just based on their genetics. Should someone be a donor? And we will get into that in another discussion in another session about organ donation. And so we, as African Americans, our high blood pressure is more resistant. On average, we require more medications to treat high blood pressure as an African American than a Caucasian. And some of my patients are on 4 and 5 medications to control their blood pressure. And because blood pressure is asymptomatic in the sense that not everyone will have a headache, not everyone will feel the pressure or the throbbing in their head. And so how compliant are you going to be taking 4 and 5 medications a day for something that you don't necessarily feel the effects of, but just have to take them? So it's easier to be non-compliant. It's easier to miss those medications or decide, well, you know what, I feel fine. I don't need those medications because you're not symptomatic. And so the decline in stages going on to worsening kidney function is often seen with the inability to stay on that regimen. Generally, I get frustrated with someone who sees a physician, the blood pressure is high, they give them a medication to help or added another medication, but the return visit is not till 3 or 6 months. How do you know that medication has improved your blood pressure? So as a patient, you have to take an active role in saying, is my blood pressure well controlled? How many times have I seen my family members come to visit and they say, you know what, I forgot my high blood pressure medicines. I'll be fine till I get home. No, you wouldn't be, but you're not going to have any symptoms. So therefore, you're not consciously aware that it's important because you figure I feel fine. And what is it? You know, it's okay to be without my blood pressure for 2 or 3 days. That is not okay. Just as it will not be okay with diabetes, but you will probably go into a high sugar coma if you don't take your insulin. But you're not necessarily, but you could have a heart attack and die if your pressure is extremely high during that time that you're not taking that medication. So it requires diligence and persistence and being able to stay compliant with your medication, knowing that you're going to require many more medicines to control that blood pressure to keep you from having a heart attack or stroke.
All right, we have another question. One of the questions we have is testing for creatinine a part of a normal blood test?
Yes, it should be. You should get what's called a metabolic panel on an annual basis, even including a lipid panel that looks at your cholesterol, your triglycerides, all those factors into how overall your body is doing. You don't necessarily need to have your liver checked, but but it should be part of at least once a year. That should be part of the panel. I see so many patients who do not get a urine check. You know, they go get blood work, but there's no request for a urine sample. So you have to make sure or insist that there's that request to have your creatinine protein checked in your urine. And it's just a simple any time of day urine sample. So that's important. It is part of your process. If you go to LabCorp, as we are now getting all our blood work done outside, or you have an ability to get a patient portal for wherever you're getting your blood work, be able to make sure you log on, get a copy, be able to see your numbers and download them. So LabCorp gives you the ability to do that. Private doctors' offices may not necessarily be linked to patient portals, so that makes it a little bit difficult, but you can always request a copy for yourself.
All right, and our next question, this is a good one. As an educator on kidney disease, what is the most important thing I can share?
Get tested. Kidney disease is silent. Unless you know your creatinine is worsening or you have more protein in your urine, there's nothing that's going to signal you to say that my function is getting worse. Swelling of the legs can just be from heart disease. It doesn't necessarily have to be from kidney disease. There's so many things that would cause you to, so don't wait until your legs are swollen. Maybe that your heart's bad, but your kidneys may be okay. So you want to make sure, but if your heart's not well, then eventually your kidneys are not, it may suffer the consequence. So all in all, if you're seeing a doctor, a heart doctor, because of swelling in your legs, they should be checking your kidney function. Because that's related to some of the medications that they may need to give you.
Here's another question. Is damage to the small blood vessels the only connection between kidney disease and heart disease?
No, kidney disease, when you think about heart disease comes from, in terms of coronary artery disease, is a buildup of of lipids, triglycerides, the bad cholesterol, what we call the HDL, being too high, too many triglycerides in your system, eating too much fat, and abdominal obesity, what we call truncal obesity. All those things factor into heart disease. All those things factor into blood vessel disease. And so oftentimes the link may not necessarily be just one of the things when you think about metabolic syndrome, which is a combination of truncal obesity, high cholesterol, high triglycerides, high bad cholesterol, diabetes, high blood pressure. So having 2 or 3 of those alone is going to give you the risk for heart disease in itself. So it may not necessarily be kidney disease, but because high blood pressure is a symptom of kidney disease, if you have kidney disease from another cause, just as your kidneys start to fail, you will be at risk with worsening high blood pressure. And that high blood pressure will also put you at higher risk for heart disease, stroke, or myocardial infarction, heart attack. So it's a vicious circle, unfortunately.
So this next comment, my younger sister was a varsity athlete at Howard when she was diagnosed with kidney disease at 21. She had no symptoms and had complete kidney failure. Get tested, sister. So that was a comment from one of our participants. And then
and that's important to understand. I'm going to interject because at 21, it's unlikely that she had high blood pressure or diabetes causing her kidney disease. She might have had a glomerulonephritis disease where there's wasting of protein in the urine, or something that comes on quite suddenly that can be manifested simply by protein in your urine, manifested by slightly increasing high blood pressures. Because as I said, without diabetes and high blood pressure, as you develop kidney disease from other causes, you will get high blood pressure, you will get protein in the urine. And for young people, they have oftentimes what's called FSGS or MPGN, which is a long name for membranous-proliferative glomerulonephritis, of focal sclerosing glomerulonephritis, which can be picked up by protein in your urine. So a simple test as a teenager or something could have diagnosed that, but some of it progresses so fast and so quickly that in most cases it's not reversible. So that scenario definitely boils down to really making sure, I just by a show of hands, or not a show of hands, but maybe if someone could just indicate through a reaction of raising their hand, how many of us get our urine checked when we go for our annual blood work? Just give me a reaction in the, okay. So I don't see a majority, but I see some. And so that's important to understand.
I'm in a meeting, you can come in. What you doing? The kidney
Okay,
meeting.
so yeah, and so like you said, not often is it ordered, so you have to remind your doctor. Hey, what about my urine? I need you to check my urine.
All right. So another question we have is, do you recommend checking your blood pressure at home daily?
If you're at risk for high blood pressure, then certainly it's important to check, or you tend to be borderline, it's important to check your blood pressure at least a couple of times a week. If you are on blood pressure medicine and trying to control your blood pressure, then you should be checking your blood pressure more often, because you want to make sure that the medications you're taking are effective, and that your pressure isn't elevated only in the doctor's office. Because oftentimes if they're calling and they say, what's your blood pressure? As we do telemedicine, we want to know what's your blood pressure at home. Because I know in the office, you may have white coat hypertension and maybe higher in the office than it is when you're home. So I want to see, show me your blood pressure log. What is it running when you're home? What is it running first thing in the morning? What is it running in the afternoon, so that I can know how to adjust those medications. So it is important to know what you are before you battle the highways and rushing to get to your office, and then you're in your doctor's office and your blood pressure is high and he's trying to adjust your medicine. He gives you more medicine, you go home and your blood pressure is lower. So you really do want to know what you are while you're at home.
Our next question is about diet. Is there a special diet to follow? I'm thinking this participant may have meant like, is there a diet to follow if you have been diagnosed, or if there even is a diet to follow to avoid certain health conditions?
Well, certainly we want to make sure we have a healthy diet. One of the things that we want to do as African Americans is control our salt intake. Put away the salt shakers, stay away from the salty food, stop eating that scrapple. I'm sorry, I can't stand the stuff. Stay away from that bacon and all that stuff that's preserved in salt. It adds to our risk of high blood pressure. It tastes great, and once a month, treat yourself, but not on a regular basis. Remember, things that are fast and convenient are high in salt and high in fat and lead to heart disease, basically. Put us more at risk for that metabolic syndrome where we're having high cholesterol or high triglycerides and lack of activity. So avoid eating out. We're home mostly. Try to eat more vegetables. You know, if you're diabetic, we usually say more vegetables and fruit, but there's a lot of sugar in many fruits. So you ought to be careful with which fruits you're eating if you are diabetic. That becomes important. So you certainly don't want to pick out on grapes because they have a lot of sugar, and pineapple have a lot of sugar, but you want green leafy vegetables. You want to exercise. So you want a balanced diet. You want to make sure that you're having less carbs, especially for diabetics, because that's where your carbs get stored. And so those carbs tend to be stored, and you go into our liver, and it's stored as fat. And yes, you do need, your body makes all the cholesterol it needs. So any cholesterol you're taking in by eating out and eating foods is in excess. So just, that's a given fact. So that was what pushes us over the bulk for having high cholesterol. That's another topic, sorry.
This is all good information. We need this. It's been so wonderful. Dr. Scantleberry, is there anything else that you wanted to share before we close out with our participants tonight? We thank you so much for this wonderful presentation.
Yeah, one of the things that we tend to perpetuate or cause ourselves to go into these cycles based on our family cooking and the way we practice our health and our food. We need to be conscious more as people of color to start breaking that cycle. I want to just correct. I'm no longer working for Christiana here. I can drop the mic on that one. I'm retired. And so, yeah, I'm a consultant and professor of surgery at Texas Christian University. But the thing about it is that we want to be able to improve our health. And unfortunately, so much stuff is going on in our bodies that we're not conscious of and we're not feeling. But drink more water, ditch the juice, ditch the sodas. Think about more water. If you're like me and don't like water, put some lemon in it. I grind my ginger up with lemon, and I now use that for just flavor my water, because I don't generally like water, but I can drink it if it's flavored. And so that's my trick in terms of, and I think about taking a big 16-ounce jug to my bedroom at night so that I know that I'm going to be drinking half of that before I go to bed and half of that when I wake up in the morning. And be conscious about that. Be conscious about your salt intake and eating out. Eating out is a death trap, really. If you really want to be conscientious about your diet, stay away from fast foods. They're convenient. And I'm glad that McDonald's got rid of biggie sizing, because biggie sizing, for an extra $1, you're getting 1,000 more calories. It's not worth it. And so think about your health overall and what you can do to improve not just your health, but the health of your family, your loved ones, and the next generation, because we've got to change the cycle. So thank you guys, be well. And someone said, God bless, and thank you so much for this opportunity. And since we didn't touch on treatment of kidney disease, I guess there'll be a part 2.
Yes, yes. So I want to talk about that, but you're getting all types of congratulations on your retirement in the chat. So many folks are sharing that they appreciate this program. Someone even put that virtual learning now is changing the game as far as, educating us and keeping us informed.
Absolutely.
Everyone is finding that this session has been very informative. So again, to our attendees tonight, thank you for joining us. Dr. Scantleberry, thank you. I can't wait until part 2. We are looking to have a part 2 to this. We're going to be discussing treatment options for kidney disease, also talking about living kidney donation. Again, please visit our Beyond the Mask website. It's a resource for Black women. These were resources created by Black women for Black women. We are so excited about this campaign and really being able to have monthly program where we're sharing health information, resources, and making sure that we're connecting. So we look forward to seeing you on March the 18th for our second follow-up program. And I think that is about it. Is there anything else for the good of the order before?
Did you get that second poll up to?
Let me try and see if I can get it going. Let's see.
If not, don't worry about it.
Don't worry about it. Okay. So let's see, relaunch and poll. Share results. Stop sharing. Yeah,
It just came up twice and it's up now.
yeah,
This is the one we did, right?
This is the one we did. Yes, I'm looking for the second one, but I don't know how to get to the second one. The second poll question was basically regarding if you knew anyone that was on dialysis. So we'll figure it out and make sure that we have it. Oh, here it is.
Here it is, yeah.
Okay.
Let's fill it out.
So please take the time to fill this out. So now I'm realizing that you have to give it time. So you have to just pause for a moment and give it time. Okay. I'm learning.
So we have 8 people who have a family member with dialysis. So yeah.
Yep, and we still have more folks polling. So we still have.
Yeah.
All right, I'm gonna give it about 2 more seconds and then I'll end the poll.
And I think that's so important to know in terms of, because there's so many there's disparities in each aspect along the way, and just in terms of diagnosis, which we haven't touched on, in terms of once you're diagnosed, what are your choices? What kind of choices are you being given? And when are you given those choices? And that makes a big difference in terms of your long-term outcome in being pointed in the right direction early on. So very good information, and it's certainly our next session will be really enlightening to those who already know someone on dialysis or someone who is a member of the family. So invite your neighbor or your friend, and we'll be able to talk more about this next month.
All right, and just to read off the results to you guys, it looks like about 5% on dialysis. So we have a person here on dialysis. 40% of our participants have a family member receiving dialysis. 25% know someone receiving dialysis. So we can see the impact that kidney disease is having in our lives. So.
Absolutely.
Well, thank you all for joining us tonight. We look forward to seeing you again next month. You will receive a post survey for you to complete. Please complete this because this is how we know how to plan programming and make sure that you guys are getting what you need from the programming that we're providing. So look forward to getting that post survey and please complete it. Have a good evening, everyone.
Good evening. Take care. Bye, Joy and Monica.
Thank you so much. Thank you. Nice to see you.
Those are my cousins.
Good to see you.
And we're saying family because eating out is a big no-no for us. So
Absolutely.
It's a family thing.
it's a family